Okay, to kind of move on with some of the other stuff that we're going to talk about. So, at least for right now, if you are kind of getting some of this stuff confused, I would just again kind of look back at some of the stuff, make sure you're understanding it, and just kind of going through that information, reading about it. Again, I use a lot of Google, a lot of like ChatGPT, just to kind of make sure I'm explaining it right. A lot of my friends' resources at the time. So I just feel like I wouldn't over stress about some of the stuff that you feel like you have to know every single little thing. I feel like there are just things that they highlight on that are more important to know, and I think that they'll help you with critically thinking, kind of with these questions a little bit more. Um, in terms of the things that you have to know, again, things highlighted in green that I have on here, but it's also like the things highlighted on purple. And the things that I kind of talk about, I try to. I think for the rest, I kind of want to stick away from exam reviews just because I think if you're not understanding like the pathway of everything, and we're doing these practice questions and they're helping. But again, like once you get up to the final, it's going to be very difficult if you're just kind of memorizing this information. So again, try to make sure you're understanding it, and it technically is memorizing. It's kind of just getting locked in your memory, right? So if you have to just memorize it and then just keep saying it over and over and over again, repetition is key. So writing it out, explaining it, I think is the best way to learn. But that's what I would recommend. In terms of some of the stuff that we'll go over, I'm not going to go over a lot of things. I'm probably just going to read through it. But again, hopefully I can at least just point out these are the things that you should know. These are the things that you should be looking up. These are the things that I can explain it in my own way. I feel like for this rest of the semester, I didn't really, I feel like this stuff was a little bit easier than the beginning stuff, just because again, you're learning new dysrhythmias, new things like with events that it doesn't make sense. And at least for like DI, SIADH, if you know some of the stuff, it's like, okay, that makes sense. I think once you get into neuro, those ones are a little bit confusing too, just because not because they're confusing, but just because they're so different and similar at the same time. You see a lot of the same symptoms, but again, hopefully I can at least just be like, hey, remember this, do this, and that's kind of what I guess I'm here for. But other than that, I'll just read through some of this stuff, some of the things I'll point out, same as always. So I hope this at least helps to have like a little review, or at least something where it's like, okay, like let me listen to just somebody explain it, or somebody just go through it. And then if you're kind of struggling, I think with like studying on your own, hopefully you could just play this in the background or use it while you're studying, so it can kind of help to start you on that. But either way, let's go ahead and talk about DI. So we talked about DKA, HHS. So those are different, right? Because you're having the hyperglycemia effects. Even though it says diabetes insipidus, it says diabetes, right? It's not the same thing as diabetes mellitus and how we talked about DKA and HHS. You have those biochemical problems of like hyperglycemia, ketonemia, and then the metabolic acidotic state. So, and then you're looking at the whole equation of the anion gap. So you're doing that for DKA, and then for HHS, you're still having the hyperglycemia even higher, like to 800, and then additionally, you are also having like severe dehydration, in which you do have for DKA, but you kind of see that more also with HHS because of the also is linked to a higher mortality. So you do like the judicious hydration, where you're also giving like the normal saline and everything there. So in terms of DI, what we're going to be talking about is ADH. So that's really the great thing is if you know DI, you will know SIADH, and you just have to really understand one of them. So I'm going to explain DI, but also explain SIADH. But I feel like, again, once you go through one, it's kind of like, it's just the exact opposite, right? So ADH, if you don't know what it is, it's in its name. So don't overthink that. Obviously, if we're giving like diuretics, if we're diuresing somebody, they're voiding more, they're excreting all of that fluid out, right? Like with a CHF patient, we're getting rid of all that fluid that's accumulating, and they can hopefully have a better cardiac output. So if I'm saying antidiuretic hormone, well, it's a hormone and basically antidiuretic, right? So allows us to keep a lot of that water. So this is also known as vasopressin. That was one of our vasopressors in our like sepsis lecture, right? So this is basically a hormone produced in the hypothalamus and released by the pituitary gland that regulates water balance in the body. By controlling water reabsorption in the kidneys, it reduces the urine output and increases the blood pressure. So again, just helps out with our like water retention, making sure that we're keeping that fluid volume good, right? So I think in this case, I just wanted to put that in there. It was just a screenshot from Google, just because, again, if you don't know what it is, then it gets a little bit confusing. But yes, ADH is secreted by the posterior pituitary gland. So basically, with DI, you have decreased ADH. I feel like the good thing about DI is you just also can remember that they both start with D's, so like decreased DI. So decreased ADH secretion, which then leads to an increased urine output, right? So in this case, we're having hyposecretion of ADH, right? So, and that comes down to failure of tubular reabsorption of water in the kidneys, right? Because that's what it's supposed to be doing. So we're having failure of that. And then you're going to end up having the opposite effect. So polyuria. And then that's could be like 5 to 40 liters a day, which is crazy. And then excessive thirst, because again, you're letting go of all of this fluid and all of the water. So in this case, again, you just have to remember what ADH is, and in this case, it's decreased, right? So obviously, we're going to be letting go of all of this fluid. So in this case, we're having a lot of side effects in terms of having like decreased blood pressure, not getting perfusion, not being properly hydrated, and we're just intravascularly dry, right? So let's talk about it more. So in terms of the different types of DI, there's neurogenic, which is, make sure you know that one for sure, because this one is central or primary. So this is caused by a defect or injury to the hypothalamus or to the pituitary gland. So that makes sense because that's where it's being produced, right? So if it's being produced in this area, the primary, central, well, it's in the neuro space, right? So we know that we're having a central or primary issue with this specific location. So obviously, if it's producing that and we're having an issue with that, then obviously we're going to be um, not secreting ADH. So this is related to head injury, trauma, or brain surgery. Again, this all makes sense because ADH is released and produced from this place. This place is injured, so it's not going to be able to function how it usually does or as well as it usually can. So in terms of the second, that's nephrogenic. So this is just related to genetics, that people just do not make enough ADH to begin with, or like the renal tubules just don't respond. So they would just need ADH daily. But in the other case, that's kind of more of a primary central issue because, again, that's where it's being produced. Nephrogenic, that just has to do with not, genetically making enough. And then obviously nephro, meaning from your kidneys, they're not responding to that. Third is drug induced, and there are certain medications right there that kind of could also lead to a decreased ADH. So those are some of the ones that you can see, but just knowing the different types, so just know nephro, drug induced, and you can like kind of know some of those meds, but really it's just also knowing the nephrogenic one, or sorry, the neurogenic one is obviously affecting the hypothalamus or the pituitary gland there. So risks: head injury, tumor lesion, surgery near the pituitary gland, infection. So like if you're having like meningitis or encephalitis, again, that's all kind of related to your neurogenic spaces. And drugs, obviously, with the drug induced that we see there. And then elderly patients are also at a risk factor. Again, elderly patients are at a risk factor for anything. But if you think about it, this makes sense because they're having decreased water content in the body overall. They're having a decreased thirst response. The decreased ability for the kidneys to concentrate urine, because obviously with time, those kidneys do deteriorate and lead to some dysfunction. Increased use of diuretics. Obviously, when they're getting older, they're going to have to use their medications. In terms of drugs with side effects of DI, so if they're having like lithium, anticholinergics as they get older, so obviously if they're taking those drugs, you can get drug-induced DI, and then increased swallow issues or just poor food intake, so they're just not being properly managed with their diet or being hydrated well enough, right? So all makes sense. I feel like it's all related just to our patho that we talked about. Manifestation wise, so you just have to think in this case, if I'm super dry and I'm just like super dehydrated at this point, what are we going to then end up seeing for the signs and symptoms? And I feel like don't overthink it. It is exactly what you think it is. So in terms of CV, well, you're letting go of all this fluid, right? So if you're letting go of all this fluid and you're just voiding it all out and excreting it all out, you're going to have decreased BP. You're going to have an increased heart rate because now your like blood pressure is super low and you're not being properly perfused, right? Because remember, we have to understand the patho of how our blood is working. It carries those hemoglobin to carry the oxygen to be perfusing to the rest of the body and to the rest of your organs. So again, if you're not having that proper blood pressure, proper blood volume, or volume in general, then your heart rate is going to have to increase to kind of compensate for that, right? So then you're going to have decreased peripheral pulses, hemoconcentration. We talked about that before because technically, if you're dry, you're, even though we'll talk about it in a second with the labs, but technically because you're dry in your space, you don't have any fluid volume. Well, then you're going to have a higher H and H because of the fact of the concentration. You have less of this, and technically you have more of this now, not because you actually have more H, like hemoglobin or hematocrit, anything like that. It's just because you have a lack of this, the concentration of that makes it seem like it's higher. And then increased BUN, because again, we know that BUN and creatinine, that should be more in the renal section, but BUN and creatinine are going to be elevated just because, again, you are dry there. And in terms of renal, obviously you're going to see increased urine output because that's the whole point. If we're having decreased ADH, we're going to have more urine outputs. We're going to have to secrete and excrete because we're not retaining that water. It's not acting on the kidney to retain that water. It's just saying let it all go. So you're having decreased specific gravity, decreased urine osmolality. And so if you don't know what that is, that's just the concentration in vessels. So now urine is pouring out the water, so now it's going to be diluted, right? So in terms of the labs, we'll talk about for serum chemistry and urine chemistry, we'll talk about that because all you have to know, and don't try to get it twisted, but I feel like it's all you have to think about is what is the patho, what is GI, what is SIADH, what is it doing? So it makes sense that this would be diluted. It makes sense that this would be concentrated. So skin, poor turgor, dry, kind of makes sense. Neuro-wise, you have that thirst, irritability, cognition decrease, hyperthermia, lethargy, coma, ataxia. And it says right here just hyperthermic because they don't have fluid, so the vessels constrict and your heart rate goes up. So that could be more of the issue why you're having hyperthermia there. Because again, kind of your heart rate's compensating, your vessels are trying to constrict. So that's just kind of the after effects because now your metabolic demand is having to meet all of these needs because you're not perfusing because again you don't have any, you have hypovolemia in a sense because you're letting go of all this stuff, fluid. So in terms of labs, serum chemistry and urine chemistry, so your serum, meaning your blood chemistry, is going to be concentrated. So again, it's the same exact thing with like the H and H, right? The reason why it's concentrated is because you're letting go of all of like you're avoiding and you're letting go of all this fluid, and so you're gonna keep peeing and just keep going, right? And so technically it's not because you have actual more potassium or anything or more sodium or anything. It's just more about the fact that you have less volume in terms of fluid, and then what's left over in there, it's just more of that concentration because again, I would think about it like almost you have like your electrolytes in there, you have obviously like your H and H, a lot of different things in your blood. So if you were thinking about it like ratio wise, you're supposed to have some fluid, right? And then you're supposed to have those components and those contents. So if you let go of all that fluid, well, your concentration of your contents and all of those things are going to go higher, right? So if you're not understanding that, I would at least try to look up some videos, but I feel like it would just make sense if you think about it like in a real life example. I'm trying to give one that's like super basic that I'm trying to think like, oh, like if you I would just think about it like a soda almost, like sodas have sugar in it, right? So if I were to take out like the actual liquid, and we were to just put like we were to see like what the sugar is in there, and now we have less liquid overall, but we have more sugar within that small amount of liquid. Well, technically, there's more sugar, not because we put in more sugar, but just because now within that space, there's less liquid in there, there's less of the actual soda, and now there's just the sugar. So now you have more sugar in that volume space. So that's what makes it be higher because it's a higher concentration. Not because I put more sugar into my soda can, but just because I drank or I took out all this liquid of the soda. Now like I have like this much sugar still, but the ratio of sugar that I have to this volume is a lot higher. So I hope that kind of makes sense. I'm trying to think of like something where I'm like, okay, to explain in like an easier way, but that's kind of how it works. So that's why you end up having the concentration there. But if you think about it, if you keep voiding and voiding, because again, with DI, you're having decreased ADH, you're going to keep voiding and voiding. All of that water is going out of your, urine. So that's why you also see it be diluted for the urine because you're gonna keep peeing and peeing and voiding and voiding. And then if you think about it, all that water's going out, and now it's just being like you're diluting your actual urine and everything there. So decrease specific gravity, urine osmolality, sodium and potassium for the urine chemistry, right? So don't get those things twisted. I think all you have to really understand is, well, if I'm going to keep voiding, 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 that's going to be diluted. If I'm going to keep voiding, 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 I'm intravascularly dry, and so now I have more content in that space, um, due to like how little volume I have. So because of that, that's what you're gonna end up seeing in terms of the concentration there. So I hope that makes sense, but really, worst case scenario, if you do not understand, you could always memorize. But again, if you just think about patho wise and think about kind of what I said in terms of, well, if you just keep voiding, 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 and kind of think about it where it's like, oh yeah, if I'm gonna keep voiding and voiding and voiding, eventually it's gonna void out, and your urine is going to get diluted because you're gonna keep voiding and voiding, and all of this water and all of this volume is gonna keep coming out, and you're diluting that because of that happening. But also, again, because you have no if you just know one, you'll know the other because one of them has to be concentrated, the other one has to be diluted. And then when you look to SIADH, the only thing that you have to know is it's going to be the opposite. But again, I think about it patho wise. I wish I could just memorize things and just understand it like that. But I have to really break it down and be like, okay, my DI patient is voiding a lot. So if they're voiding, the urine should be diluted because it's going to keep being water, water, water. And then in terms of the serum, so the blood, well, now I don't have any like actual fluid volume there. So all of the contents that are in the blood are now going to be a lot higher. Um, so that's kind of how I think about it. Complications, obviously a fluid volume deficit. You have a decreased cardiac output because again, your heart rate is now having to compensate for the fact that your blood volume is so low, or your fluid volume, not just blood, but fluid volume is so low. And you have a risk of electrolyte imbalances, obviously, if you're going to have your serum chemistry be um, concentrated. In terms of that, you can then see those dysrhythmias, disturbed thought process, because again, you are dry intravascularly, and you have those dysrhythmias or electrolyte imbalances, and then impaired mucous membranes just because they can get dry. And then if you're not doing the proper oral care for that, then you can end up causing a lot of different injuries there, get an infection if there's like a wound now. And then for management, kind of the same things. I don't even feel like I have to read it, but in a sense, basically vital signs, urine output, every single thing that we're talking about, because what we're talking about is basically um, you're dry, and then, oh, no, you're not dry, now you're, like, overloaded with fluids for SIADH, right? So, basically monitoring, like, their weight, their CVP, that's your overall, pressure within your body, right? Or not pressure, but just your fluid status that lets us know the fluid status of the patient. And then for skin, mucous membrane, skin turgor, for labs, like, for your urine and your serum, you look at your sodium, right? And so you can give D5W to dilute it because, again, for that serum chemistry, it's going to be concentrated. If you give D5, those hypotonic fluids, you can then decrease that sodium there. And obviously, that's going to be for the provider's protocols, but again, or your hospital's protocols as well. And then same thing with potassium. If they're going to be really high, well, we talked about those different direct and indirect things that you can do. BUN, creatinine, specific gravity, all of those things. Diet wise, you can keep them on a regular diet, but you restrict foods that have a diuretic effect because they're already diuresing so much because you're having decreased ADH. So, caffeine can do that. I don't drink coffee or anything, but I know that I drink a lot of like Diet Cokes and like Coke Zeros. So add bulk foods and fruit juices, and then also PRN if there's constipation. So just keep in mind they still need to have fluids with laxatives or fiber as well, and then you promote safety there. For treatment, so you're going to replace their volume because again they are dry. So like always, we're going to be giving isotonic fluid. So I wonder which ones we're going to give, right? So 1 mLs IVF per 1 mLs of urine output. So if you assess your patient, they voided like 50 mLs in one time, you're going to give them 50 mLs of IVF because you want to keep them properly hydrated. And if you keep, let's say, in a sense where you're only giving so much and you're giving a specific rate and you don't tie it to the urine output, Well, the problem with that is you're gonna kind of have to keep chasing, and they're never gonna actually be hydrated because you're gonna keep hydrating them, and then they're gonna just keep letting go of all the fluid. So you have to match that. Um, and then ml, so it's basically mLs to mLs replacement for that. And then just think about it, even though we're giving normal saline, what's the difference? Well, again, they're dry, they're having decreased ADH, they're diuresing everything, so you're gonna give the urine output there. That's also based on the last hour. And then additionally, if they're having hypernatremia, you could give D5W for that. And then we just talked about that to dilute that because it's going to be concentrated because again, you have less fluid volume overall. Those components are going to be more concentrated there. So in terms of the neurogenic cause, and this is why they also want you to know it, is because of the fact that you can give desmopressin. So that's basically synthetic ADH. So it's just a synthetic um, basically analog of vasopressin. It's considered stronger, so you can either give it intranasally, daily, orally, or parenterally. So IV, which is usually what you're going to be doing. But that's why specifically with this one, neurogenic, that's more of again, if it's drug induced, what can you do? Well, don't take those drugs or talk to the provider about switching those drugs, right? If it is are nephrogenic, well, that's kind of more genetically related, and your renal tubules aren't being responsive. But again, you can just get ADH, and we can give that. But specifically to the neurogenic, those are like head injuries, traumas, brain surgeries. We can give desmopressin to help with those things, and that's just straight up synthetic ADH. And remember, ADH, vasopressin, desmopressin, they sound the same, so that's why we're doing that. Um, so yeah, that's pretty much it. And then again, you have to know the treatments for that. You have to understand the types. You have to understand it's decreased ADH, what's it doing, and then the labs, right? So understand those things. Okay, so now getting to SIADH, what's the difference between those things? Well, you just have to think that they are going to be the exact opposite. So increased ADH secretion. Okay, this one has um, basically leading to water intoxication of your intravascular volume. So you're going to be basically fluid overloaded a lot. So because at this point, again, we know that ADH basically helps with the water reabsorption, acts on the kidneys, does everything that they have to do to retain that water. So if it's increased, that means you are literally having so much water retention and fluid retention, and so we're going to see some of these things. So what are the risks associated? Well, we know for DI, those are the three different types. Any type of brain surgeries, things that we talked about, um, elderly patients. So in terms of SIADH, well, malignancies, I don't think that they ever really explained what was the background of this, and I should have probably looked into it before I hopped on here. But let me actually look it up and see if there's a reason why. I think one of my friends asked in class, and I think Mandela was like, I actually don't know why this is the cause of that, but basically risks malignancies is a small cell carcinoma of lung, which is the number one cause. Um, and maybe it could be related to kind of having an increased intrathoracic pressure because of the pulmonary disorders next to it. Um, it just says on the internet, SIADH, where cancer cells produce and release ADH inappropriately, just because of that. Okay, this is going into a lot of other things. Now it's talking about like tumors, specifically to small cell lung cancer, and how the cells just are releasing it, paraneoplastic syndrome. So, it's causing those issues. Okay. But either way, it's just small cell carcinoma that is the biggest risk that you're seeing there. Um, and that's the number one cause. So she says, or if they say that there's a patient who comes in, they had a diagnosis of small cell carcinoma in their lungs, well, you should probably be thinking SIADH is the issue. So again, I think the good thing about this one, what I did is like, well, it starts with an S, small cell carcinoma, don't make it harder than that. In terms of pulmonary disorders, increased intrathoracic pressure, which is having a higher PEEP, TB, pneumonia, COPD, CNS disorders of a head injury, kind of similar to before with DI, and then drugs, kind of similar, but different drugs, obviously. We had like phenytoin and TCAs with the other one. This one, you can have ACE inhibitors, amiodarone. But really, the big one that you kind of just need to know for the risks is the small cell carcinoma, just because, again, that's usually the number one cause for this issue. Manifestations wise, neuro, so you're having a lot of fluid shifting to cerebral tissues, and that is going to be our big thing, especially because we're going to give a different type of fluid for this one. This is the one that's different, as well as when we start getting to neuro stuff, that's also going to be different types of fluids we're giving. We're not going to give NS, but I think it's important to understand, at least for this, you're also seeing a lot of the neuro fluid shifting to cerebral tissue, so that's why we're also going to be doing, and like the effects that has on sodium, that's why you can also do like hypertonic saline. But anyways, we'll talk about that in a second. But basically, restlessness, headaches, hostility, disorientation, seizures, coma, nausea, vomiting, poor appetite, because again, you have so much fluid in you, you don't want to really be eating, abdominal cramps because of that. Obviously, you're going to have weight gain, increased BP, CVP, PCWP. So PCWP being like that left side, right? CVP more of being, I think, that's also similar to the right atrial pressure. So that's the right side. So what are the differences? Well, you're just looking at your volume status in both sides of that heart, right? Because anatomy wise, one is coming before, and then it goes out to the rest. The other side goes out to the rest of the body, but it goes like back from the lungs. So anatomy wise, that's kind of the stuff that we're talking about. Remember with hemodynamics. But really, you're just talking about fluid status. So overall, if you're having a lot of water retention and water reabsorption because of the ADH being increased, you're going to have increased everything, right? So respiratory wise, pulmonary edema, because again, that fluid has to go somewhere. Labs wise, so this is the difference, right? So stereochemistry is going to be diluted because now you have so much fluid volume, your contents are still the same. So if I were to again grab the soda, I'm just going to keep pouring the liquid part or the water, whatever they use to make that liquid part. I'm going to keep pouring that in, and all that sugar in there is, I'm not going to add more sugar in there. I'm just going to add the liquid part. Well, now that it's going to be diluted in the ratio that I have from my sugar to my fluid volume, and the liquid there is going to be different, right? It's going to be diluted. So decreased sodium and serum osmolality, risk for seizures, because again, with like your sodium being low, all of those things, that it's you're going to have that effect, right? And now with your serum, your urine, right? Your urine chemistry, it's going to be concentrated. So you're going to have increased sodium in urine osmolality. So the exact opposite. So just kind of read, if it says urine, it's going to be concentrated. If it says blood, it's going to be decreased, right? So make sure that you know those things. It's just the opposite. But then again, if you're thinking about it, for this one, for the urine especially too, well, you're not having a lot of urine output, so all of that is going to be concentrated because now we don't have any water going through, and all those contents in the urine are going to be a lot higher and concentrated because again, that water's not going through it. It's just kind of, you're going to try to avoid, but here are all the things. They're all going to be concentrated because again, you have no fluid volume that's going through it. In terms of management, well, fluid restriction, right? Kind of again similar to a CHF patient. I'm not going to keep giving them fluid because the whole point is they have a lot of fluid, right? So you put them on a fluid restriction. Same exact thing with this, where they're having fluid overload, and then we know with fluid overload, this fluid has to go somewhere, and it makes it harder for the body to meet that demand of having to work. So fluid restriction, 800 to 1,000 mLs per day, so 1 liter per day, essentially. And again, same things, monitoring your vital signs, urine output, weights, I's and O's, CVP. It's going to be probably high, right? And then obviously your PCWP, and that's just the same exact thing as the CVP, but it's on the opposite side, it's on the left side. And then monitor serum and urine labs, obviously, because they're going to be diluted or concentrated. And then medication-wise, loop diuretics, right? Because we need to give diuretics. Furosemide affects that water retention and everything there. And then demioclocicline, I can't say it, but basically that's another medication that can help with that, and it's used to also treat infections. So that's why we give that. And then in terms of hypertonic saline, so this is the one that's different, but we do this so we can get the sodium back, right? So basically we know that with the other DI, you could give essentially D5 because your sodium is going to be very concentrated. So then you can go ahead and let that go. A little bit decreased because again, those are some of the effects that we're going to see. But for this one, if it's going to be concentrated and we have those risks, of all of this like cerebral edema and fluid shifting, we want to go ahead and also give hypertonic saline so we can also get that sodium back. So basically, for this, these are you 100% have to know the treatment and understand why we're giving hypertonic saline, right? So looking at the sodium, it's less than 110. That's when we start to really make sure we're giving it. It helps with the seizures and the coma because obviously we know that the sodium, if it's super low or even high too, but you're going to see effects within your neurological status. So that's where you see the AMS, you see seizures, comas, and then in terms of the infusions, usually it's 1.5 to 3, but it can go up to 9%, but different than our usual like 0.9 normal saline. But complications, right? Uh, Central, I can't say it, but myelinosis, or I just say osmotic demyelination syndrome. So basically, the problem with doing this and the problem with trying to help your sodium, um, if you do it too fast, you're at risk of having this. And what it is that basically the sodium is changed too quickly. Your nerves, your demyelinated nerves, right? Um, you can lose the conduction of the nerves, and then eventually you're not going to be able to move. So you can definitely affect a lot of your nerves and what's happening there. So you want to make sure you're doing it at a consistent rate in terms of your sodium. It's kind of like with your blood sugar, like with DKA, what we talked about. You have to make sure that you're decreasing it, checking it every hour, not going more than like 100. So it's almost the same thing. It is the same thing essentially, but different reasons why we're worried. This one has more to do with the nerves, but again, just make sure that you're checking that. And we'll talk about that literally here in a second. Other complications, heart failure. Of what you, but really we're more worried about the osmotic demyelination syndrome. So you're going to infuse it slowly, no more than 8 MEQs change in 24 hours. You absolutely need to know that. So if they give you a question and it says something where it's like, okay, this patient was given this at this time, their sodium was this, now it's this, well, you got to either decrease that rate, increase the rate. You have to read on what it is, but you'll see the changes there. But just know it can't be more than 8 MEQs in 24 hours. If it's like 10, well, looks like you're gonna have to slow that rate down, or you can't be increasing it. You can't be doing anything there. So monitor sodium level every 4 hours, and so you're gonna be checking that as well. So that's why like every 4 hours you'll check if it's like how much am I going down. So that's why and they talk about it like, so if you're checking it every 4 hours, and you work within your 12-hour shift, well, you're looking at it like 3 times, right? But then you have to make sure you give report to your nurse and be like, at this time, imagine if it was like 2 hours in, or for the first 4 hours in, you're looking at it, and then you already have a sodium change of like 4 MEQs. Well, it's only been the first 4 hours, so if you keep going at that rate, by the 8-hour mark, you're probably going to be at 8 MEQs, right? So if you keep going at that rate, you're at risk of having the osmotic demyelination syndrome. So then it's like important to look at that and be like, oh dang, okay, so let's contact the provider. Let me check based off of my protocols. Let me decrease it. What do I have to do to make sure that I'm not going at a specific rate, so that we're not having more than 8 MEQs. And you want to like do it all the way throughout the 24 hours. You don't want to just have it like, well, why don't we just do it within the first 8 hours? Because again, you have that risk of having the osmotic demyelination syndrome, and you want to do it slowly. You don't want to do it all together because again, fluid shifting, the nerves get damaged, and you still have those risks. Even if you do the first like 8 within the first like 4 hours, I wouldn't do that. You want to spread it through evenly as well. And then seizures wise, complications, yeah, seizures because of the hyponatremia, electrolyte dysfunctions or disturbances, fluid overload, obviously with this one. So again, one, the other. It's just the treatments you kind of have to think a little bit more about, but that's kind of what we're seeing there. In terms of organ transplants, you guys will talk more about this with Legacy at the end of the semester. I think we got tested over this for the final of everything that you have to know. But the good thing about that stuff is you kind of just have to know it, and it's pretty self-explanatory. But at least for this stuff, again, you can get transplant in organs, bone marrow, tissues, bone grafts. So you have that. So what is the goal of transplant medications? So I knew this for the exam, but we didn't get tested over it but we got tested over it in the final. So a lot of people didn't think that you had to know it. So again, I would know it. I would make sure you at least know this stuff because again, it also will help you when the time one legacy comes. I don't know if you guys already had that talk, but basically, it is interesting here. In terms of goals, so suppressing the immune response, prevent rejection, because again, we don't want them to have that immune response reject it, and now we just basically did a whole surgery for nothing. And then in terms of avoid opportunistic infections, maintain graft function, and then again, you just want to make sure overall you're helping the patient with that rejection, because to prevent rejection, the medication that you have to take to maintain that could be lifelong. And then to treat rejection, we could do high dose and additional medication to reverse. So other than that, for maintenance, specific protocols, patient and transplant specific. So it would again depend, is basically what this is saying. Higher dose on normal, and then with corticosteroids, they must be continued, right? So basically here, there's a difference between maintenance and then treating the rejection as well. So we want to maintain, if a patient has this surgery of organ transplant, we're going to give them these meds, and then we'll do that. These are going to be lifelong. And then for treating rejection, if they're having that specific issue of rejection, you'll see it, then it's like, okay, on top of these drugs, we're also going to have to treat it with these other things here. So cyclosporin, which is common, that also, she said this, but I think it's interesting. But you don't have to know it, but it's better with chocolate milk and in a glass. And then myclophenolate, which is common, tacrolimus, I don't know how to say these, and then corticosteroids. So you're going to be on them early on, high dose in rejection to stay immunosuppressed, so you're not having that immune response be hyperactive. Specifically, she does mention though cyclo and tac should not be used together because of the nephrotoxicity. I knew those things, so I just kind of was like, okay, CMTC for the maintenance, CT should not be together. In terms of treating rejection, this must be used with patients who are refractory, so that means that they don't respond to the maintenance medications over here to the left, right? So you're going to have them on the high dose of maintenance drugs still and on the steroids, right? Because that's still a part of the maintenance. And then basically OKT3 or muromonab, basically it's going to be through the IV, and it slams on lymphocytes to stop the rejection process from happening. So OKT3, that's to treat rejection, the maintenance. So every single thing that you're going to be doing to treat rejection is everything on the left plus the muromonab, the OKT3. But basically, you're still going to be doing the maintenance drugs. They're just going to be higher doses. You're still going to be doing the steroids. Maintenance, you don't do the other medication. You just do what you have to do there. But at least for CT, psych, and TAC, they shouldn't really be together because of that. Therapeutic effect, immunosuppressed, adequate graft function, and obviously you're going to have to look at the side effects of whatever organ or transplant we did. So if it was a kidney, we'll look at the kidney, stuff, right? Urine output, a BUN, creatinine, liver dysfunction, LFTs. Are they having any type of jaundice? Like anything that you're going to see with defects of the function there. Lung fibrosis, gingival hyperplasia. But remember, because we're giving these steroids, the side effects of those steroids could be gingival hyperplasia. That's a big one she hits on. So those GHATs, they're not going away. You still need to understand them. You still need to know them, especially with the steroids here. So just take a look at that stuff. We talked about it in past semesters. But just know the big one, at least Mandiola hits on, is the gingival hyperplasia, because again, you're having the overgrowth of gum tissue. And then you have to usually have gum scraping to take it out, and it occurs over time. It's not just going to happen overnight, but it is occurring over time. And this is just highlighting on the fact that, again, there are still side effects to our medications that also, on top of the organ transplant, are not fun, right? So drug-resistant infections, so to kind of talk about this, a drug-resistant infection is an infection caused by bacteria, viruses, fungi, parasites, and they have now developed the ability to resist the effects of medications like antibiotics, antivirals, antifungals, or antiparasitics that would normally eliminate them. So what is then the difference between colonization versus the infection? Well, colonization, you have an active microbe, but you don't have an actual infection, right? And then once the infection starts, that's where you're having the proliferation of those microbes, and they're actually causing symptoms. So whenever I got COVID, my last semester of school, which I found I've never gotten COVID before. I thought I was dying. I didn't know what it was. I thought it was the flu because I got a flu shot, and it was COVID. And I don't know when I got it, but I do know when I started feeling the symptoms and I had the infection and was positive. So that's whenever I was having that actual infection because now I had a fever of like 101. My heart rate was like 130s, 140s, like lying down. My body was so weak. I felt super short of breath. Where I literally thought I was having a heart attack. So I went to urgent care and I was like, I don't feel good, but not emergency department level, but they gave me an inhaler, a bunch of other things because I was like, yeah, I don't feel good. But those are the differences there. So patho-wise, and this is something that I feel like you should know because they did test over this, or at least Mandela did, but it's something to also it makes sense when you talk about this stuff. So I guess with how do bugs gain their resistance to begin with? Well, they're antibiotics, they're overusing it. Um, so obviously through time, and I kind of think about this with elderly patients, they're just going to take their meds whenever they want, or they take it too much. So frequent or unnecessary use of antibiotics. So using them for viral infections, you're using antibiotics, but it's not going to work for that. And then exposes the bacteria to these drugs repeatedly. So then it encourages the bacteria to now adapt and to develop this resistance because you're overusing it to the point where it's getting used to seeing these antibiotics. And one, you could be using it in a way where it's not actually like supposed to be helpful, but this bacteria now knows it, develops it. It's really interesting how bacteria is able to do that on their own. But that's also why like we have differences within the flu vaccine every year. COVID is very different as well. So there are different strains. So if we kept using the same like flu shot every single time, it probably wouldn't work or give us some of that prevention there. So not completing antibiotic course, I feel like these two make so much sense because again, you tell them all the time, if you don't finish your antibiotics, like it's not going to work. So again, I was on Paxlovid, I think, for my COVID. There's one of the side effects, and I had to look this up, but because they didn't tell me, is that you have like a metallic taste in your mouth. I swear, every time I took that med, it felt like I was eating like pennies, and I was like, it was so terrible, and I did not want to finish my antibiotics, and I had one more left, and I was like, okay, I'm just gonna finish it because I already knew at that point, like I had no symptoms, I was already negative on a test, but I was like, I need to finish it because of obviously, hello, I'm talking to my patients about completing their antibiotic course. So when patients don't finish their prescribed antibiotics, basically some bacteria could still be left over and they now are able to survive. They're going to become tolerant of the medication and now they can proliferate again. So if you don't finish it, like with mine, even if I said I don't have, it's like when some people are like, well, I'm taking my hypertension meds and now my blood pressure is going down. So I'm not going to take my blood pressure meds anymore. When it's like, well, that's what's keeping your blood pressure down consistent to begin with. So for me, it's like, okay, if I'm feeling a lot better. I'm testing negative on the test. Nope, you still got to finish your antibiotics because, again, this is what data has said, research, evidence based practice has said. So do it, finish it, and then make sure all the bacteria is gone, and then go on from there. So yeah, these surviving bacteria can then multiply, proliferate, now passing on their slightly resistant traits because again, you didn't finish the entire antibiotic course. You expose them to that, and now you have leftover bacteria that's still there. They're able to grow again. Now you got an infection again, and you're feeling those symptoms. For enzymes producing microbes, so some bacteria can produce enzymes that inactivate antibiotics. So for an example, certain bacteria produces beta-lactamase. That's basically an enzyme that breaks down beta-lactam antibiotics. So that's like penicillin. So it does that before they reach their target. So basically, bacteria get smart and they develop a new way to neutralize the antibiotic. So yeah, it's basically what the name is. So enzymes producing microbes. So they produce these enzymes that specifically inactivate some of the traits of certain antibiotics of how it works, right? That's more of like dealing with things in like lab and pharmacy, and I don't know the science behind every single medication, but in terms of just knowing, that's an example there with the beta lactamase, and then that can then end up affecting with like penicillin. Um, so fibrin coating, that basically some bacteria develop a fibrin coat and it's like a shield. And so that helps them to basically protect them against antibiotics and the body's immune system to fight it off for the bacteria. So then the coating would make it harder for the antibiotics to directly, go into the bacteria to go to the bacteria's core and then to um, basically attack it. So now the bacteria can survive, proliferate again. So this one kind of just think about it like fibrin coating kind of sounds similar to like our fibrin, what we need to use to like fibrinogen, making like clots and everything. But yeah, so having a coat, having that bacteria be protected, now antibiotics can't physically go in and kill it or go to its core to attack it. And then the last one is efflux pumps. So basically, bacteria, I'm going to kind of read it, have efflux pumps in their cell membranes and they act like bailout systems. So basically, they expel antibiotics out of their cells. When antibiotics enter the bacterial cell, the efflux pumps then pump them back out, effectively penetrating the drugs from reaching high enough levels with the cell to be lethal. This pumping action allows the bacteria to withstand the effects of antibiotics by keeping the concentration low within their cells. So again, I would just think about it like bailout systems. They basically take the antibiotics out of their cells after you give them the antibiotics, basically making it kind of redundant why we're doing this in the first place. And so yeah, once it enters into that cell, the efflux pumps bump them back out. Now you can't reach the bacteria's core, and we don't have enough antibiotic in the actual cell or bacteria cell or anything going on. So if that's the case, well, again, they can kind of get used to that uh, or become resistant, and kind of now they know what the antibiotic looks like, and then basically they can keep living, surviving. Now you got proliferation and everything there. And so again, because they allow like some of the possible antibiotic to go into it, they get some of the drug basically, then they can get used to some of the drug and be like, oh yeah, well now I kind of know what it looks like. So the next time you give it to me, I kind of already am used to it because again, bacteria's goal is to, kind of go into your body and attack you and take over as much as they can. So mechanisms of transfer, you guys already know this, read about it. Again, if you're not really having, you kind of get these confused or having issues, contact, right? Skin, tissues, airborne, vectors, you guys know those. Prevention is the number one key always. Hand hygiene, complete your antibiotics, make sure you follow what your doctor told you. Um, Appropriate isolations for rooms is a big one for us, and then surveillance of high risk populations. You treat yourself PRN in terms of the symptoms or things that you're seeing. So you guys can read on the standard contact airborne droplets. You guys know it. And then for this, I don't even really want to read it just because, again, I don't think that they're going to test you over it. I could be wrong. But read about it, kind of just write it out, I would say, for the most part, and talk about it in case you're like struggling with some of this stuff. But for the most part, with MRSA, it's a type of staph aureus bacteria. I'm just kind of going to read it. Resistant to methicillin and then other antibiotics, right? Because obviously it's methicillin resistant. Um, so it's found in the nares. So that's again what we do on admission, right? So found in nares, wound, and systemic infections. So Vanco is a treatment for it. You want to worry about with a lot of these, especially with Vanco, your renal function. Absolutely, that's a big like NCLEX question too. Um, Basically, clindamycin, sulfonyl, uh, line lisinolid, I can't even say lysolid, basically also similar to Vanco, but it's not as hard on the kidneys. C. diff, we all know what that is. Unfortunately, C. diff is a bacteria in the GI tract, obviously can overgrow. You see the severe diarrhea, and now you got disruption of your GI flora. Very antibiotic resistant as well. So yeah, you can give those medications. Same thing with Vanco, metronidazole orally. And then again, it could be more effective sometimes when they take it orally, especially in this case with C. diff, right? Because we're talking about like GI infections. Um, Fidasocmycin, newer antibiotic, targets specifically C. diff. Probiotics can help restore that normal gut flora that we like to see. And then fecal microbiotic transplant. That's basically FMT. So basically, transplant of healthy fecal matter via an NG tube or colonoscopy to restore your regular healthy gut bacteria and reduce symptoms like abdominal pain. Because again, we do want some of our own bacteria as well to help us with our immune system there. So I think that's pretty interesting, and I feel like this one makes sense because it's C. diff, like you all know what it is. And then in terms of vancomycin resistance, enterococcus. So again, vanco resistant, right? So this is a type of bacteria also found in bloodstream, wounds, lungs, other areas. Again, same thing with the medications there, just taken to the same effects of like renal dosing. It could be effective, could be resistant. There are new ones here that you can kind of see. And then you see the beta lactams, which is kind of closer to what we talked about earlier. And then extended spectrum beta lactamase producing microbes. So this is what we were talking about with like the different types of things that you're seeing, like the enzyme producing microbes. So beta lactamase, right? The bacteria can produce that, so then it can become kind of resistant to those beta lactam antibiotics like penicillin. So right here, you can see that this is also ESBL is producing bacteria, so that's also Pseudomonas, Klebsiella, E. coli, all of those other ones producing an enzyme that break down beta lactam antibiotics. So those are the penicillins and cephalosporins. Because again, she asks you, like Mandiola specifically asked, what are your allergies, right, to penicillin, cephalosporins. So anything that ends with illin, anything that starts with like CEF, CEPH, so like ceftriaxone, all of those other ones. And then they're also um, usually resistant to carbapenems, which is one of the strongest classes of antibiotics. The reason why I wanted to just kind of go over this one though is because the treatment, you can also still give carbapenems because yes, it can be resistant, but they're again one of the strongest classes of antibiotics. So let's just try it and let's see how if it's effective or not, or if it's resistant. If not, then again, you can add aminoglycosides, which is effective against some, and then colistin, which is just an older antibiotic, and it's kind of being now reintroduced for multi-drug resistant infections to help those pathogens that haven't been used to seeing it because it is kind of older. So we're not getting them used to it, especially because this is the beta lactamase producing microbes. So the bacteria literally produces that to go against the specific medications here with the penicillins. So because of that, you can give like this medication because it was kind of older and maybe they're not used to seeing that. But really with this one, you're kind of just trying your best to help with those things. And then management wise, you guys already know this stuff. Like it's the same things as always, like antibiotic therapy, make sure you're finishing it, right? Empiric versus broad spectrum, right? Shortest duration to eradicate like hydration, culture and sensitivity to see what's going on, wounds, isolation, CBCs for the WBCs. Like you guys already know this stuff. Renal function's a big one, just because again with these a lot of these antibiotics, like Vanco, you're seeing a lot of the renal function there be possibly nephrotoxic, and then ABG status, right? Acid base balance, like with sepsis, respiratory issues, maybe nutrition, making sure that they're having that proper protein intake to support their immune function and to help with healing of any wounds or anything there. Oxygen, wound care dressings, medication side effects, right? We talked about earlier with the organ transplant, how you should know the GHATs with the corticosteroids. Same thing here, knowing nephro effects. GI upset, they're probably already having like diarrhea, nausea, vomiting with their infection, but now on top of that, those antibiotics have a lot of GI effects that we always learn about. And again, immunosuppressants for giving these antibiotics and everything. So you could also have a lot of increased infection risks, and they already have an infection, but things like C. diff, we can also give probiotics to also help restore that bacteria and that flora that we naturally have. And then you can kind of just read about this at the end. This is just more stuff to kind of know from here as well. But yeah, I'm gonna pause it for a second and then we can maybe go over the neuro stuff. Okay. So now going into some of the neuro stuff, I would just recommend to read some of this stuff. I'm not really going to go over it just because, again, I think this is more of things that it's just review. And if not, I mean, I don't really remember a lot of these things myself, and I probably should review some of this stuff. But at least for this part, I just would recommend to kind of read about it and just to kind of, you don't feel like you have to memorize these things or like really understand it. I think it's more of, I would try to at least kind of know some of the lobes because I feel like those are some questions that I remember they kind of ask, but I can't remember if it's like in this semester or like last, but for third. But I do think that I've gotten like one or two questions, and I do think that they are unfortunately on like ATI. But I think also I've seen like the nerves on ATI as well. But yeah, so one thing to kind of say is at least for cerebral blood flow, so that's also talking about, the blood flow that's going directly to the brain, right? And we're making sure we're maintaining that proper perfusion because it is still an organ as well. Internal carotid arteries, they supply that to the middle parts of the brain. The circle of Willis has that whole entire system set up. And then the anterior middle cerebral arteries also help with to provide blood into those specific lobes as well. For the blood-brain barrier, that's a selective permeability barrier, just kind of how we have like our cap permeability, like our capillary permeability, where it has things come in and out. Well, specifically to our blood-brain or our brain, we wouldn't want every single thing to just come in and out wherever it can, right? So we have the specific barrier to make sure that it's protecting the brain from any like substances that can be very harmful, and basically only allowing the essential nutrients to pass through as it should. So yeah, so the blood-brain barrier is critical for just maintaining the brain's microenvironment and protecting it from toxins and pathogens from entering as well. So that's just important to know. I feel like that's kind of just something that they hit on, but the other stuff too. And we'll probably talk about this as I probably will go over the rest of the stuff as we talk about like some of the hematomas, herniations, things like that as we start talking about that, because you see a lot of effects on your autonomic nervous system. So things that your body does automatically, right? Like your heart rate, breathing. So when you reach those things of like your spinal cord, well, we know that there are nerves in there, and you're talking about like your autonomic nervous system. When we talk about herniation, edema, all of those things, we're going to start talking about, well, where does all that fluid go? It goes down to your spinal cord. Now you got effects in your heart rate, all of these autonomic things, because again, it's affecting that. And that's what we're going to talk about going forward. But I'm not going to talk about it now because I feel like, again, it kind of hits more on those things later. Cranial nerves, basically, you do kind of have to know the cranial nerves. There are specific ones. You don't have to have everyone memorized, but I could be wrong. But it kind of just depends on what they're asking. But I do think there are specific ones that they do kind of point out, especially for mandiola. And honestly, you should know it because on the NCLEX, I did see these questions on there. I remember. I don't know if I got it on my actual NCLEX, but at least for my practice tests on Archer, I got like 2 or 3 like cranial nerves, and I was like, well, if I didn't know this, I would have gotten it wrong. So basically, cranial nerves that we'll talk about in charge of sensory and motor functions in the head and neck, and kind of specifically we'll talk about those differences. So just kind of key parts of the assessment, neurological assessments hourly, especially for these neuro patients. When you work in like a neuro ICU setting, you have to keep checking in on them, and you ask, like, you obviously kind of assess like their GCS. If they're intubated, you know, they're not going to have any verbal response. But can they move? Like, can they still understand me in terms of like obeying the commands of like, hey, like, can you like give me a thumbs up? Could you push on my hands with your feet? Can you squeeze my hands? Can you make sure they're still having that those sensations there, and the ability to not decline in their neuro status, right? So some of the symptoms, well, we'll talk about it, but I feel like these make sense. Vomiting, headache, visual changes, motor changes, cranial nerve responses. So GCS. Do you have to know specifically like which one they are? I don't think so, but you should know how to use the chart. So I think the question is kind of just making sure you understand like what the chart is, and it's like, oh yeah, they obey commands, they do this, like, so it's like, okay, if they're having to pain, then it would be this. If they're having, I'm pretty sure she gave us a chart. I don't think you have to memorize it. However, you do have to memorize the posturing and kind of just know it. So with GCS on the motor scale, right? So then you have posturing, and it's all the way at motor response. So if they're obeying commands, they move to localized pain, and you'll kind of know. You can ask them, even if they're vented. You can, if they're not responding to you and they're not obeying your commands, then it's like, okay, you can give them a little sternal rub. You can I kind of push down on their nail beds here at their hands and on their feet, just because, again, I want to make sure that they can actually move. And then sometimes you do that, and then you're like, oh, they're still not moving. Okay, they're not having any response at all. Well, if they're on any sedation or anything like that, and again, it depends on your hospital protocols and the way that you guys run things, but for us at least, we don't want them to be like the RAS score to be at a specific point. For some patients we do, obviously for some we don't. So like -2, you know, -3, but like once we get to the 4 to 5, you know, we have to try to sedate, take off some of that sedation. So that's also kind of what you can do. But specifically, at least for the posturing, it says abnormal flexion or abnormal extension, right? So decorticate on GCS scale is a 3, and that is, you do need to know where it's at. So that's your upper midbrain damage. For decerebrate, that is technically worse. It's not technically worse. It is worse, and that is on the 2 for the GCS scale. And remember, the goal is to obviously have a higher number. If you can't remember that, well, the little like phrase is like when if you're less than 8, then you intubate. So if you have a lower number, no bueno, right? So that's not good. So 2 worse, decerebrate worse due to damage further out. And so again, that makes sense because you're now also having damage further out. And we kind of talked about really quickly kind of some of the effects of like, oh, when you start going down to like your spinal cord and hitting those nerves. And this is middle to lower brain damage as well. So I think one of my friends said it, but she came with this thing where it's like when you're decerebrate, you don't celebrate, like or something like that. So I kind of think about it like that: cerebrate, no celebrate. So that's worse. So that's a 2, and that's going to be the middle to lower. And then the corticate, that one's in, so like it's to your core. They're going to your core. So when you're looking, it's like they're going to their core, kind of pointing in inside the core. So decorticate, right? And then decerebrate, they're going out. And so again, why would that be worse? Well, it depends on the location, but also if you think about it, they're still going in, so they're still sort of they're not flexing like within to like localize their pain, but it's like at least they have some sort of thing where they go inside. Whereas once they're going like curling out and everything, that's just a lot worse. And I feel like it makes sense too, because it's like you'd rather go inside to your core to, localize that. But it's definitely not good, both of them. But just know one of them is worse than the other, and that's the cerebrate. That's a 2. That's middle to lower brain. The other one's going to be just upper midbrain. That one's a 3. Terms to know, definitely read on this, just because again, I still need to read on this sometimes within my assessment and be like, what does these mean again? Especially with starting. But yeah, make sure you kind of look at these. But really, it's just knowing the posturing. I would just look at it, study it for a second. You also don't need to know the motor strength. At least they didn't test us over that, but I feel like it makes sense, and you kind of already start to know it, like when you start doing it a lot. Um, Sometimes I forget the actual like terms where I'm like, oh yeah, it's against gravity, but they can still maintain it, but or whatever. But I kind of just look at it and I'm like, oh yeah, that looks like a 3 because like they're still able to hold it up, and then but obviously grade 0 less no good, right? NIHSS, so low score is also the goal. So size of the brain here, basically size of the brain lesion and severity of stroke is kind of what we use it for, and kind of just to make sure that they're also not declining. So that includes 11 items. You guys got the NIHSS certification. And so we still do have it on the unit, so you can still look at it. Like you don't feel like you won't forget it. And I think Mandela says this, but it's not like a lot of people are actually doing it, unfortunately. But at the same time, it because it takes a really long time to be able to do that. And then for cranial nerve assessments, in terms of what we should know here, there are things that you can do to like draw it out. I would definitely practice to know these things because again, as you move forward, you might have to know what they are. But if you get tested on it, like an NCLEX World, but either way, the big ones that they kind of test on are the ones that Mandela points out. So your pupil response, that's cranial nerve 3, and that's usually going to be just looking at the eyes and seeing if you have that eye movement problems, if they're having pupil constriction. Corneal reflex, that's 5 to 7. Basically, you place a cotton swab near your eye and you test it to see where they're blinking. And then you test for a cough and gag reflex, that's 9 and 10. I actually think that some of these I removed because let me make sure I'm right on that, because there are some stuff where I'm like, okay, let's see here. There might be. I think that's the one that I just opened, but let's see. This one. Yeah, so let's do this one because I was gonna say there's some stuff that I removed because technically I was kind of reading it and I was like, well, 5 could also be this. So let me make sure so that even I was like, okay, wait. So at least for and this should be updated on your guys's. I feel like I did do that, but so basically pupil response, cranial nerve 3. So again, kind of talking about that for the reflex, the next one, it's just gonna be 7. So that's just your facial nerve, and that's just you put a cotton swab near their eye and you see if they can blink. Also, when you walk into the patient's room, you can also just see if they're kind of blinking when you're moving and doing all of your assessment stuff. So that's kind of how I see it there. For cough and gag reflex, obviously if they're vented, you can go ahead and check if they need to be suctioned. As PRN with that. And then you can see also if they're taking anything orally. And then in terms of their cough, is it weak? Is it strong? Is it like non-productive, productive? You'll see those things, right? So cranial nerve 9 and 10 are for the cough and gag reflex. So that's the glossopharyngeal and then the vagus. So you do a test on this nerve again with the Yonker inline section whenever they have. So I feel like those make sense. It's just kind of memorizing this one for this one, this one for this one, this one for this one. So I memorize all of them, but usually the one that I feel like they test on is the cranial nerve 7 for the corneal reflex, and then cough and gag for 9 and 10 for those. And then what do? Well, you put a Yonker. So it's like, don't get it confused because it's like, okay, cough and gag, or like, what would you do for to assess cranial 9 and 10? You would put a cotton swab near their eye. Well, that's not right, right? Because that's the Yonker one. So make sure you also, it's like a three-parter. Like, what would you do? What is it for? So osteocephalic. So this is the doll's eyes, right? So 368. And she says like 368 doll's eyes, So aren't great. So basically, C spine clearance first because you are going to basically be moving. So if they have like a spine injury, you have to make sure you're holding it and putting them in C spine, right? So this allows for the eyes to doesn't allow, but we want to check if the eyes follow and maintain a forward gaze. So basically, or if their eyes kind of go in the opposite direction. So abnormal is absent. So basically, when you're turning your head, your eyes just kind of go all over the place. So when you're turning your head, you're gonna tell them to basically keep their eyes on you. And so then when I get it kind of confused too because I'm like, wait a second. But basically, if I were to tell a patient like, okay, I'm holding like their C spine, making sure they're good, I'm gonna tell the patient to like look at me. Well, if I'm looking at like the screen, my eyes still kind of follow. They go in the opposite direction, but do you notice how they're still going there? If it's abnormal, well, they're just kind of going all over the place. So like I can't even maintain like if I were to be looking at the camera, like I can't even look at it. Like there's no way. So 368, if they're doing that, that would be abnormal. If they're just kind of like, I can't even look at the thing. Like I've had patients, I think during clinic where it was like they couldn't even look at you or like stare at you. They just kind of have to, you know, or their eyes just kind of go back and forth, back and forth. And they think that they're looking at you, but they're not. So yeah, that's kind of just make sure you're getting C spine clearance first, obviously, and then allow for the eyes to follow and maintain basically that gaze. So their eyes should kind of go in like to follow you basically in the opposite direction. And then if they're just kind of going all over the place, then that's going to be different there. And then for the oculovestibular reflex, that's basically just the cold caloric test. I didn't actually put what specific cranial nerve it was because I don't think she said it, but I would just ask just in case. But basically, if basically this is just an involuntary reflex, have the client face forward, and then you're gonna basically put in cold saline or water into their ear. Basically, if their brainstem is intact, they should be looking to that side. But they have to make sure that they have a tympanic membrane that's intact, just like with the C spine clearance, because you're going to be moving their head essentially. Um, Basically, you want to do the same exact thing with their ears. So yeah, that's just kind of straightforward. You just kind of have to know what it is. What are we talking about? And then what are you supposed to be doing? What are some of the precautions? So obviously, like tympanic membrane, C spine clearance for those there. And then I don't know if she has you guys doing these things yet because I feel like she didn't review this with us. But just in case, one thing to know is if they have glucose, that's usually kind of indicative of bacterial meningitis in their CSF. And then for at least the ICP, late signs of ICP are the Cushing's triad and then the reflexes. So this is the last hemodynamic response to increased ICP. This comes out of the foramen magnum, so that's kind of where we start seeing that edema. That brain has to go somewhere, and that affects the autonomic stuff. We'll talk about that more later, but I feel like again, some of the things you can see are the widening pulse pressure, bradycardia, and irregular respirations. And then last but not least, hopefully there's not another thing that you guys have to know, but the other thing is just with meningitis, you have those Koenig signs and Brudzinski signs that you can possibly see as well there. So that's just indicative of meningitis. The knee one is the one that starts with the K. So I feel like that's pretty easy to remember. And then The B1 is the one that you're bending their neck and seeing if there's hips and knees flex, and then with the Kernig's, obviously, you're seeing if they're able to flex their knee, and are they having pain, can they do that? So just make sure you know that as well. I don't think she, like, has a specific slide for it, but she does want you to know it. So just make sure, again, you're knowing those things. But other than that, that's pretty much it for this stuff, so I hope it's able to help, and then, yeah, I wish you guys the best of your best luck on your guys' exams always, but you're almost done, and you guys got this.